Good evening, everyone. Thanks to everyone for joining this live webinar. I'm Professor Ahmet Fuat. I'm a GP in Darlington in County Durham, about 15 miles from Barnard Castle, which I'm sure you all know now. I am also a GPSI in cardiology and have an interest in thrombosis through that. So tonight we've got a really great panel of speakers. We'll hopefully have time for lots of questions. This is being co-hosted and endorsed by Thrombosis UK and the Primary Care Cardiovascular Society, and we also have a Primary Care Respiratory Society member. So we're going to look at how general practice should consider patients with respiratory issues in a time of COVID-19. And we will take questions at the end. This is being recorded and I believe will be available for viewing later on, certainly through the Thrombosis UK site, and we'll make it available on PCCS as well. So I'm going to start I'll introduce speakers as we go along. So our first speaker tonight is Professor Beverley Hunt. She's Professor of Thrombosis and Hemostasis at King's College and Guy's and St Thomas's in London. She's been in the heart and the heat of COVID-19, through which we've been living through for the last 3 months. She's an expert lecturer and researcher in thrombosis and medical director of Thrombosis UK, as well as many other positions. So Bev's going to guide us through the natural history of COVID-19, COVID pneumonia, and discuss the timing of development of a prothrombotic state, which we recognize is one of the reasons why COVID-19 infection can be very serious and fatal with this hypercoagulability. But Bev will tell you a great deal more about that. So thank you very much, Bev.
Thanks very much. And I think it's my role to set the scene for everybody, just to remind you all of the natural history as we understand it. I've done lots of talks about COVID and thrombotic risk. It's really important to put the date on the set of slides because what you say this week might be out of date next week as we learn more. So just to remind you that thrombosis and hemostasis has got a set of rules, and I think they often get forgotten. So actually, the coagulation system developed as an effector system of the immune response. So we know that the whole point of it is to lay a wall around invading bugs so that they are entrapped and they can't exert themselves on the host. The second sort of rule is that the endpoint of inflammation is thrombosis. So if you think about profound inflammatory diseases such as Behçet's or the vasculitides, if you've got really bad inflammation, you end up with a thrombotic event in the microvascular system where the inflammation is. And we give anticoagulants, but we don't expect them to reduce the thrombotic rate. We actually need to treat the thrombotic problems, the inflammatory problems with anti-inflammatories. And indeed, the management of Behçet's has changed dramatically since we got certain biologicals that alter its outcome. And then lastly, hypoxia is a profound stimulator of the pro-inflammatory response. Because we've got transcription factors that bind to certain genes to switch on the prothrombotic ones and switch off the anticoagulant ones. So when we think about COVID, we need to remind ourselves that COVID enters the body through the respiratory system and it's binding to the ACE2 receptor on the pulmonary epithelium. And because the pulmonary epithelium surface is so vast, it's got huge entry. But as it enters the body, it's also going to be binding on the endothelium of many vessels, adipocytes, macrophages, and lymphocytes. And luckily, most people tend to have minor infections. They may be asymptomatic, or they might have a bit of cough and fever, or they may have anosmia. And the issue for the clinicians in hospital is that we are admitting patients because they have COVID pneumonia. If you look at the proportion that have COVID pneumonia, it really depends on the underlying population. If you've got a younger population, such as you might have in India, it's going to be a smaller population than the portion that we see here in the UK. And the problem with the pneumonia is that you're getting a profound inflammatory response. And you've got activation of lymphocytes, macrophages, and a huge cytokine storm. So we are treating the pneumonia because they're getting hypoxic with oxygen. Moderate is when you treat it just with supplementary oxygen. Severe is when you need mechanical assistance. And one of the consequences of that cytokine storm is you get really high levels of IL-1 and IL-6, and they go to the liver and cause increased production of coagulation factors. So you have a profound prothrombotic state. And this is happening, if we look at those who do get COVID pneumonia, they tend to have an underlying inflammatory state anyway, because the risk factors are increasing age, diabetes, obesity, and cardiovascular problems, and they all generate a prothrombotic state. Just to remind you that something like obesity is not just having excess adipocytes. The adipocytes themselves produce a fair number of cytokines, and some of the cytokines they produce, such as IL-1 and IL-6, will make the body more prothrombotic. And we know that the adipocytes have got the ACE2 receptor on their surface. So COVID is getting into the adipocytes and probably increasing the production of inflammatory mediators. So just to show you what's going on in hospital, this is our data from Guy's and St Thomas's, which has now been published, very similar to any other unit. So this is the first 66 ventilated patients in intensive care. This is with the March data. We had in April, we had 190 ventilated patients. So this is the start of the pandemic in the UK. What do we see? So first on the left at the top, we've got Klaus fibrinogen, functional fibrinogen, normal fibrinogen 2 to 4 grams per litre. What have we got in those with COVID pneumonia? Really high levels. So median levels of about 7 to 8. I've seen values since then of high as 14 grams per litre. I've never seen such profound inflammatory changes. And then we've got very high levels of D-dimer. You'll notice that that scale is logarithmic. And so normally a D-dimer would be less than maybe 0.3, depending on the assay. And we've got levels up to 10,000. And we've got other inflammatory markers, procalcitonin, ferritin, and CRP at the bottom, and they are similarly raised. And all of these factors are moving together. So this is part of the effect of IL-6, IL-1. The other thing to say is that the data that came out of Wuhan right at the start was deceptive. So they said, oh, there's DIC in all these patients. There isn't. There really isn't. They misinterpreted the data. We've got this amazing acute inflammatory response. We've got near normal PT, APTT, and we've got high levels of platelets. And you'd expect prolonged PT and APTT and a low platelet count in DIC. So in hospital, we are struggling with a set of problems in that when we look at the lungs, we've got high rates of pulmonary embolism. I mean, we're stimulating all aspects of Virchow's triad with those who have COVID pneumonia. So we've got immobility, they're on a ventilator, they've got this amazing inflammatory response. And then also we've got endothelial cell activation because COVID infects the endothelium. So a real triple whammy for having hospital-acquired venous thromboembolism. But we've also got going on inflammation in the lung, and in the areas of high inflammation, we're seeing what we call, for want of a better term, immunothrombosis. So that's local microvascular thrombosis in the lungs because of the inflammation. So I don't know where the rest of my slides have gone. I'm just going to, Joe, do you have my slides? Because I seem to have not had all. Anyway, I think we'll stop here because the issue is that these patients have got increased thrombotic risk in a hospital, but we also have increased thrombotic risk, I would suspect, in those who are socially isolating and who've just got COVID. So we know they probably don't have this incredible inflammatory response, but we have a lot of patients who are at home and they are less mobile than they are normally. If you talk to people who have been at home, almost everyone seems to put on weight, so increasing the risk factors for thrombosis. And then the other issues are that we have patients who are at home who appear to have had COVID pneumonia but decided not to come to hospital, or they're in care homes. And again, we aren't really managing from the hospital perspective. So I'll stop there. Thank you.
Thank you very much, Bev. I'm sorry I only got 12 slides from the, so okay. I don't know what happened to the rest of yours.
Don't worry.
Fabulous, very sort of educational session. And as you say, I've heard lots of different talks over the last 3 months, and there's been so much evolving and changing. I guess you do have to put the date on to keep up to date. So that was really superb start and opener. I should have said at the beginning, we have a question and answer button. So please send in questions, and what we'll do is we'll all come back together as a panel at the end to discuss these questions. And Bev is going to come back later and tell us about a couple of very interesting cases that she's been involved in. So I'm going to now move on to Dr. Matthew Fay. I've known Matt for many years, a close colleague and friend, I'd say now. We have very different tastes in music, looking at those guitars behind Bev, and we have argued about that before. But Matt is a GP and GPSI in cardiology in Bradford. He is also Chief Executive of Affinity Healthcare, which is a super practice with 26 partners covering 64,000 patients in Bradford. And he has interests in many areas of cardiovascular disease in primary care, but in particular in atrial fibrillation and thrombosis. He's held lots of posts, including AF National Lead. He gives his time freely to be a trustee of several charities, including Thrombosis UK, AF Association, etc. So Matt's going to talk to us about patient presentations in primary care, the differential diagnosis, why they may be atypical in this COVID pandemic, and talk us through some of the things that we could do to diagnose those. So thank you very much, Matt.
Thank you very much, Ahmet. I'm glad to call you a friend. I'm just going to think about how primary care particularly, but how our whole healthcare system is now going to have to think a little bit more closely about breathlessness in the patient presenting in primary care. One of the things I would like to highlight is we did see a dramatic change in the level of demand in general practice when COVID lockdown was announced. We'd already seen a slight decline. This is data from my own practice based in Queensbury in Bradford. And we've been monitoring our access for a short while. And as you can see, at the start of March, as the reality of the COVID pandemic coming to England really got going, just as Professor Hunt was showing us there, we started to see a decline in patients coming to our services. At the point of lockdown in the middle of March, things really did plummet, and we managed to get down to a demand level very similar to Christmas week. And remember that in Christmas week we have 2 bank holidays, so that's 3 working days, and we have sustained that level of access, that level of demand for several weeks. So we have patients who we know would normally need to present to us, because we know that patients are coming to us with healthcare needs which need urgent attention, and yet they all seem to vanish from our demand. The other thing I would like to comment on is also that very rapid change that we had from how many patients we were actually physically seeing. So before the COVID outbreak, the Willows and the sister practice over in Thornton in Bradford had already gone to a doctor first access system, but we were still seeing about 50% of the patients who called us. We were doing a lot of telephone consultation, but still seeing a great deal of the patients who called us. And then overnight, we plummeted that physical attendance down to single figures per week. So in the first week after lockdown, we managed to get down to 5 patients who were physically seen in the practice. Of course, with our practitioners fully clothed in appropriate PPE. I think this is going to change the profile of how patients are actually presenting to us. But when we look at that in general practice, we need to also consider what happened in A&E, because that also showed a dramatic change. So this is not just access or practice, the front end of the NHS right across the board. Now, some of that should be expected in A&E, of course. If people are socially isolating and not getting out of their homes, then they're not crashing their cars, they're not falling out of trees. Our schools have closed, so they're not spreading the normal spring bronchiolitis around. So some of this can be predicted by the fact that disease has been halted due to social isolation. However, there's disease that normally presents in casualty that is also missing. Now, of course, the big concern, both for primary care and for A&E, is what's happening to all that cancer that normally would be presenting to us, because we know that that's a significant issue. And as we can see from the NHS data itself, there has been a dramatic fall in the number of people who are being presented with tumours. So this is going to mean that the pathology is out there. Many may have also heard that during the heat of the epidemic, as Professor Hunt called it, we had coronary care units and angio labs which were empty, where normally they would be working 24/7. So that means there's a lot of heart disease which has now disappeared below the spectrum as well. In Bradford, my partnership also runs an endoscopy service that had to close, obviously, due to COVID, and would normally diagnose a gastric tumour once every 6 weeks. Since it reopened 2 weeks ago, it's finding a gastric tumour every day. So the tumours and the pathologies which we know were out there are now going to come through the system. So let's think about breathlessness. Now, we can often think of breathlessness as those people who present to us acutely, So they're acutely unwell with the sudden onset of breathlessness. If we just split these down into simple categories, we can think of the person who's gone into acute pulmonary edema because their heart failure is decompensated, the severe asthmatic, and of course a key one, particularly for the members of the trustees of Thrombosis UK, is the pulmonary embolism. A diagnosis that we all know can be difficult at the best of times. We know it's often missed both in A&E and in primary care, but without that classical presentation of sudden onset of breathlessness and chest pain, which may have happened in mid-March, but the patient chose to socially isolate away from us, they may now be presenting with a less clear history, a more chronic history where, due to laboured breathing, they're now starting to get chest pains, and we may be moving into a different diagnosis, even though the fundamental pathology is still that of a VTE event. Professor Hunt also quite rightly highlights the fact that the advice that we are giving to the general population is that if you only have mild symptoms of COVID, then you should socially isolate. You go home and you will feel ill in your own home. You may take yourself to bed, bringing immobility into the equation. You may sit and just play computer games all day. Again, bringing immobility into the situation. So people who we know are at risk of thrombosis because of COVID may also fail to attend and fail to present to us at the time we may have been able to recognise their symptoms, because the advice at the time was to not attend if possible. So, not wanting to steal my co-host's thunder, and Katherine's going to talk much more about presentation and the history of breathlessness, I just highlight this slide to show what we'd normally have got out of our textbook, how we may have thought about breathlessness when we were back in medical school. And now we have to remember that some of the history may be lost in memory because it was months ago. Some of the signs may have been resolved due to the fact that the body has fibrosed or healed in other ways. And we may not be finding that classic history that shows us the way. So what do we do if the acute episode's lost and we have to try and work on the memory of a history and what is we can find in the patient at the time? And I'm suggesting that we need to now think of ways to structure our investigation of breathlessness, and this is just something I've put together about how we may wish to consider it, to say, what can we do to ensure that we can look for breathlessness in a very concise and very structured manner? One of the other things we have to consider is how many times will we want a patient to visit our institution and be investigated in different ways to try and get to the diagnosis. We need to now consider pathways of care so that we actually contact our patients as infrequently as we possibly can to give a high quality and standard of care. This was just my suggestion. I'm going to just change my slide format for a moment and just have a little view into the cardiovascular world. Because what about heart failure? This is a disease which we don't do well at the best of times. Most patients with heart failure are not on optimal medication. Heart failure untreated has the same prognosis as lung cancer, but we don't seem to treat it as well. During lockdown, we may have had people who've chosen not to go to hospital because they didn't realise they were having a heart attack, so could have post-myocardial damage, poorly controlled hypertension. You're going to get people who are presenting after periods of quite marked immobility, so they're going to be cardiac deconditioned, so when they start to get active again, their heart failure may be much more symptomatic. And of course, we had that early scare about ACE inhibitors and ARBs, and we may have had patients who, doing their own reading on the internet, have chosen to stop really important preventative medications in heart failure. So again, I would suggest that we need to think about how we are now going to treat our heart failure patients and actually make sure that we get them on the maximum medication as quickly as possible. The team in Bradford, myself in primary care, and the team in the hospital have been looking at how we can now consider the heart failure pathway And what you can see in the slide on the table on the screen is that we've made a decision to try and bring some medications right up front. If we see that the patient has marked heart failure, then we are going to make sure we get the ACE inhibitor and then Entresto in first, then move on to bisoprolol, then spironolactone, at which point blood testing becomes much more intense and therefore much more consuming of our workforce. And only after that may we then move on to consider dapagliflozin as well in trying to make sure that we maximise our treatment for heart failure. So just in summary of my small section of the presentation, I think we need to remember that we asked our patients to stay away, and they may have stayed away with significant illness, which may have been easier to spot at the time of their symptoms starting. And now here we are 100 days later, and we may find that the history is harder to understand, the signs have become obliterated, and we also need to remember those people who we knew to have significant disease, who have not been able to access up titration of their medication, and also may have discontinued some medication because of scares earlier on in the COVID epidemic. Thank you for your time.
Thank you very much, Matt. That's a great analysis of really where we have been in primary care. I'm actually very proud as a GP the way we've stepped up to deliver a comprehensive digital service and helped our patients and continued to see them when we've needed to. But I'm also concerned that the backlog and the reduction in diagnosis of things like cancers, heart failure, and as we're going to hear later in VT as well, in many of our patients. So thank you for covering that. So if we move on to Katherine, Katherine Hickman is a GP and GPSI in respiratory medicine across Bradford and Leeds CCGs. She's the primary care lead for the National Asthma and COPD programme and chair of the Primary Care Respiratory Society. And Katherine's going to talk to us about how general practice should consult patients with respiratory issues. I've been looking at the questions, and there's already been a question about what we should be doing about spirometry. Perhaps Katherine will answer that during her presentation, but if not, we'll come back to that in the Q&A. So thank you very much, Katherine.
Thank you, Ahmet. That dreaded moment when the patient has been talking for the last 8 minutes about what they had for lunch, their piles, their conjunctivitis, and their grandkids. And suddenly, with 2 minutes to go, when you're about to grab your lunch or leave on time, they say, "Oh, by the way, I'm also breathless." That feeling of utter dread that you are now not going to have your lunch or leave on time, and you're going to have to start scrabbling around to find that breathlessness pathway that your respiratory lead sent an email around about a few weeks ago that you've completely forgotten about. And what it can do is induce a state of breathlessness in you as a clinician. But actually, you're not going to get breathless. You're going to take a deep breath and you're going to do a couple of things. And the first thing you're going to do is you're going to assess whether this is an acute episode of breathlessness or whether this is something more chronic. And if it is acute, I hope that you would have probably picked that up in those 8 minutes, because the patient may be short of breath sat in front of you. But actually, there are things that you can do very quickly to assess your patient. So pop an oxygen sats monitor on the patient, feel the pulse for rate and rhythm, and listen to the chest. And if any of those are flagging up reasons why the patient needs to be in hospital, it's important that even in this time of coronavirus and fear from patients about wanting to be in hospital, that you refer them into hospital. And I think I'm conscious that I have sometimes been more reticent about sending patients into hospital, but that is not, if you have an acutely breathless patient in front of you, it's important that you get them the treatment that they need. If you've established it's not acute breathlessness and it's more of a chronic picture, actually, there's still quite a lot you can do in those couple of minutes, but it's also acknowledging to the patient that this is something that you're taking seriously, that you are going to need longer to talk to them, and you may need to bring them back for a longer appointment to focus specifically on their breathlessness. I want to acknowledge at the moment that for many of us, both in primary and secondary care, we are doing a huge number of virtual, either telephone or video consultations. This is something I've done telephone triage for years as a GP, and for the last year, I've also been doing video consultations. I am confident managing a lot of things over the telephone or video. If a patient, though, says that they're breathless, I would want to see them face to face and examine them and assess them in my room rather than over the phone. So with regards to detective work, and with the absence of some of the tests at the moment, the detective work starts the minute you set eyes on that patient. Are they breathless as they're walking from the waiting room to your consulting room? Are they struggling to finish sentences on the phone? Can you hear a wheeze? Are they cyanotic? Have they got pursed lip breathing? Are they breathless when they walk up the corridor, but then that settles when they sit down? While you're looking, you're also listening. And this is going to be so important at the moment, as I say, in the absence of some of the diagnostic tests that we have available, to really listen to what the patient is telling you. And not only listen, and if they're not telling you what you want to hear, then you do need to start asking some questions. How long have they been breathless? And try to establish a pattern of the breathlessness. If they are post-COVID, can you use the MRC score to establish how breathless they were pre-COVID and how breathless that they are now? Thinking about other things that could be causing the breathlessness. Are they tired? Have they got weight loss? Or is their bra fitting, not properly, or their trousers loose? Have they got a wheeze? And if they say they've got a wheeze, you need to establish what they mean by a wheeze. Very often patients talk about a Rutley chest when they mean wheeze, whereas actually it's more of a whistle. Have they got a cough? Is it dry or productive? And are they describing a tight chest? Think about other causes of breathlessness, as Matt has alluded to. So heart failure. Are they describing palpitations? Have they got ankle swelling or chest pain? How many pillows are they using? Are they only getting breathlessness on exertion, or is it at particular times of the day? Are they waking at night? If you have access to a breathlessness pathway, it's a really good way of making sure that we're not pigeonholing patients based on our assumptions. So thinking that just because a patient is a smoker and they're breathless, they must have COPD. Just because a patient mentions hay fever, they must have asthma. If they've got a cough, well, it must be a smoker's cough, or they've got reflux. Are we thinking about other causes of their breathlessness? Are they coughing up daily purulent sputum? Could this be bronchiectasis? Think outside the box, because there are a huge number of things that can cause breathlessness, not just the lungs. So it's now time to get your hands on the patient. And as I said earlier, there are some really basic things that you can do in your surgery. Pulse oximeter, check the pulse for rhythm and rate, count their respiratory rate while you're doing that, listen to the chest. Are you hearing creps? Is there wheeze? Are there fine basal inspiratory crackles that might mean there is an element of fibrosis there, or heart failure? And it's really important that you decide what you're going to do with the patient based on the findings that when you start to examine the patient. There's been a lot of discussion recently about how we measure exertional desaturation in patients. So we have the unvalidated tool whereby patients are asked to walk for 40 steps with an oxygen saturation monitor on their finger looking for desaturation, or the sit to stand test, which is done over 1 minute to see how many times the patient can sit to stand. That is a validated test, unlike the 40 steps. And this excellent paper by Trish Greenhalgh that talks about, you know, if there is a 3% drop in pulse oximeter reading on exercise, it is a cause for concern and probably means the patient should be seen in secondary care. And it's also important to remember, because there has been talk about patients having oxygen sats probes at home, that it's not recommended that they do either of these tests if their oxygen saturations reading are below 96%. So where do we go from here? Once you've examined the patient and taken that history and observed the patient, you then decide what investigations they need. And if they haven't had these in the last 6 months, an up-to-date chest X-ray and an ECG are probably almost essential on all patients presenting with breathlessness. And you may or may not want to do some blood tests as well, particularly if they've not had them in the last 6 months. So for blood count, thyroid function tests, maybe do a BMP if it's more erring towards the side of heart failure, use an EASE and LFTs. Now, as we alluded to earlier, spirometry currently is not being done in primary care, and I read something this evening that we're not looking at doing spirometry in primary care until 2021, and that there are no current national guidelines with an agreed consensus on this. So currently the Primary Care Respiratory Society has produced a position statement on their website which talks through how we diagnose respiratory conditions in primary care without access to things like such as spirometry and pheno. So as I've alluded to, the importance of a history and examination are paramount at the moment. I know, and we know from the National Asthma COPD audit in primary care in Wales, and also national data, that up to 25% of people on COPD registers don't have COPD, and many of them will be on those registers because of inaccurate spirometry traces and interpretation of those traces. And that's why actually at the moment I don't think it's a particularly bad thing that we're not able to do spirometry, and it is a time and opportunity to assess how spirometry is performed in your practice, and if you are not confident that your clinicians are up to speed with regards to training in administering spirometry and or interpreting, then this is a really good opportunity to talk with your CCG about setting up diagnostic hubs, maybe as part of a PCN model. So for diagnosis in primary care at the moment, we are going back to basics and using our good friend, the peak flow meter. So for patients who you are considering asthma, it's about sending them home with a peak flow meter, making sure you get a baseline peak flow reading before the trial of any treatment, particularly for those patients who you have a high suspicion of asthma. It's essential that you know, although this is a very simple piece of kit, it's essential that you know how to tell a patient to use a peak flow meter, because otherwise it's virtually useless if they don't know how to use it. But not only about how to use the peak flow meter, but also to make sure that they can fill out a peak flow diary as well. And what you're looking for is that variability in the peak flow readings, at least 20%, particularly with the dip in the morning. You may want to combine that with a trial of treatment and measure, you know, if you start a trial of treatment with inhaled corticosteroids and measure the peak flow readings over a longer period, say 6 weeks. And equally with COPD, in order to make a diagnosis of COPD, we need to demonstrate no reversibility, so fixed airways obstruction, done on either a post-bronchodilator spirometry or with CT demonstrating emphysematous airways. But what you can do is you can use a peak flow meter in somebody that you suspect has COPD, and what we're looking for is if they have a peak flow reading less than 75% of normal, then this is suggestive of some form of obstruction. And if there's very little variation over a 2-week period and it's not really responding to spirometry, you could make a cautious diagnosis of COPD and give them a trial of treatment with a combination LABA-LAMA inhaler, put them on a waiting list, tell the patient that you're not making that diagnosis just yet, but you will do a confirmatory post-bronchodilator spirometry further down the line. Thank you.
Thank you very much, Katherine. I love all your picture slides, which were fab, and you know, your back to basics is a good message. So I'm going to bring back in Prof. Beverley Hunt. So Beverley's going to show us a couple of very interesting and actually very sad cases, certainly one of them. We'll, I think, then go straight on to questions, because we've got quite a few come in, because that will cover the discussion that we were planning. So thank you, Beverley.
Thank you. We at Thrombosis UK have had a couple of stories that's made us think about what's happening out there in the community. And so I'm going to share this first one with you. This is very sad. This has actually been in the national press, and it was on several BBC News outlets over the last week. So this is a 24-year-old. He was a sports coach, and unfortunately he was furloughed during lockdown, and he got quite depressed, and he seemed to spend most of his time gaming and living with his father. And his father said that he would often see him at breakfast, and it was quite clear that he hadn't actually been to bed that night, and he'd been gaming and talking to his friends over the internet. And then he was watching television a lot, and he wasn't exercising to the same amount that he had before. He complained of an ache in his calf, and it felt like a pulled muscle. And one day he was very lightheaded and he passed out. And he phoned up NHS 111, and they suggested that perhaps he had a pulled ligament and told him to rest. And his ache continued, and he felt generally off and more lightheaded. And the family didn't quite get it, and so he rested even more. And then 2 weeks later, his leg got very painful. He blacked out again. They called 111 and then the paramedics, and he was found, and he wasn't resuscitatable. And at post-mortem, the coroner confirmed that he had multiple pulmonary emboli. And this is really a classic tale of venous thromboembolism. We've got this amazing immobility that he had. We at Thrombosis UK recognise that gamers are particularly at risk. We did some surveys years ago of people working in the city, and it's quite extraordinary how many of them sat at their desks all day and then would go home and game most of the evening and not get up from the sitting position and resist the call to go to the toilet or to go and eat something. We know that if you sit immobile in a chair, as we are doing just now, well, I am, hopefully you're not, for 90 minutes, the blood flow through your popliteal vein drops by 50% because you're absolutely dependent on muscle contraction to push the blood up. So it's really setting you up for DVT. And the other things about this case that are so classic, well, he had an ache in his calf. And those pictures of DVT in the surgical textbooks, you can just forget them. That big fat swollen leg, that isn't a standard DVT. The standard DVT is pain in the leg and no swelling and no redness. That's 80% of them. And then the other issue about pulmonary emboli is they can present as collapse, as he did. There's a beautiful Italian study that looked at people who were over 60 and fainted in Italian emergency departments, and 10% of them had pulmonary emboli. So it's the forgotten presentation of PE. So this is a lockdown story. And then the second story that we have, whoops, I'm just moving it on. Here we are. So this 27-year-old contacted Thrombosis UK, and she's a bit of a crazy exercise dude. She's a horse rider and she's training for half marathons and exercising daily. And she got pain in her calf with no obvious cause. Now, 27, I'd be asking her if she's on the combined oral contraceptive pill. We don't know. Most people who are on the combined pill, if they're going to have a VTE, will have it in the first 18 months. So I would have wondered if she might have changed at 27. Anyway, she presented with intermittent cough and severe breathlessness. Spoke to her GP and he said, well, you might have COVID, which of course is totally appropriate. Tested her and she was negative. And this continued, and she had recurrent episodes of shortness of breath and a bit of pain, and spoke to her GP 6 more times. And again, he thought she might have COVID, but didn't really think about pulmonary emboli. And it's often the case. I don't know what it is, why pulmonary emboli fall off the list of any symptoms in the chest, but they do seem to. Anyway, after about 4 to 5 weeks, she woke up breathless, and this time she had a swollen leg. So she got taken to the emergency department and obviously had a deep vein thrombosis and multiple PE. And currently she's on anticoagulation, and she's got post-thrombotic syndrome with quite a lot of pain in her leg and unable to walk. So really, I mean, this case just reminds us all that, I mean, for me, I am medical director for Thrombosis UK. I would want you to take away from this webinar as a key fact that DVT presentation is all about pain, and it's not about swelling and redness. And I think I'll leave it at that because I think it's discussion time now. Thank you for listening.
Absolutely. Thank you very much, Beverley. There was one quick question. Did the first case have COVID as well, or do we not know?
No COVID. No COVID. This is just sheer immobility. I mean, it's quite well recognised that gamers will have venous thromboembolism. The first deaths in gamers were reported about 20 years ago. Yeah, okay. We've got lots of questions, so shall I just pull some of them out? There's quite a few around the diagnosis of VTE. So questions like how useful, if at all, is D-dimer in diagnosis in the context of COVID-19? If D-dimer is not appropriate, what should be the threshold for referral for CTPA? And I think a very valid point from a GP who says we never do D-dimer in primary care for possible PE. If we suspect diagnosis, we admit. Is it now okay to do D-dimer in primary care for a patient presenting with post-COVID chronic breathlessness? So several questions around that. Okay, so D-dimers are really raised in COVID pneumonia. And it's nothing really to do with coagulation. I think most of the D-dimer is coming from the lung. The lung itself, the lung pneumocytes are able to produce urokinase and switch on fibrinolysis. So the D-dimer is a marker of the breakdown of the fibrin that's deposited in the lung, because acute lung injury, you're laying down fibrin. We use D-dimers to exclude pulmonary emboli. And if you have a negative D-dimer, then that's still useful to exclude pulmonary emboli or DVT. But if you have a COVID patient with a positive D-dimer, you're going to have to go on to do imaging. But it doesn't necessarily mean that they've either got a DVT or a PE. D-dimer is a reflection of inflammation and thrombosis. So if it's negative, that's great, you can exclude it. But if it's positive, there is something going on which may be thrombosis.
Okay.
Hi, Julia. Can I just have a moment as well? Julia,
Sure.
Julia's local to me. I think the reason I put D-dimer in the list is to make you think of thrombosis. That's why it's in the list. The major issues don't diagnose PE, DVT is because we didn't think of it, and we have to think of it. And all those people who would score a high Wells PE score, yes, I agree, they need to be admitted to hospital, if not discussed with MAU about having ambulatory investigation. But the problem is those patients who have PE and are not classical. And if you do the D-dimer and it comes back at 1,000, you're going to do something about it. Similarly, as Professor Hunter's just said, the person with pain in the calf, if you don't think about the DVT, if you don't do the D-dimer because their Wells score is 1, then you'll miss the DVT and they'll present with PE. As you know, my little cardiology service over at Westcliff, the number of times people are sent through as heart failure from chronic breathlessness and they turn out to be chronic pulmonary embolisms. Yeah. All it's in there for is the aid memoir. It's to make sure you think about thrombosis. Those people don't have the classical presentation because the majority of patients with VTE do not have the classical presentation.
Okay, yeah. And there's an interesting one here, to bring Katherine into it. So thanks, Matt. I agree with that. Apparently, you can buy a kit for patients to do.
I knew you were going to ask me this.
For £125, if a patient insists they want spirometry and wish to buy it, would you recommend it?
No, I wouldn't recommend it. It's absolutely up to them if they want to spend £125. But if they come back with the result, I'm not going to code them on the system as COPD. But not apart from the fact that you need, in order to diagnose COPD, you need a post-bronchodilator spirometry. So no, I mean, I've pre-COVID, I've had massive issues with spirometry being done badly in primary care. So I can't then advocate a patient doing something that I don't even know is validated at home. So that would be a categorical no.
Yeah, good.
And it's not often I say that, but I think that would be a definite no.
Absolutely. And there's several questions again about when should we consider anticoagulation in patients post-COVID. In fact, someone actually said, should we anticoagulate everyone post-COVID? Any thoughts on that, Beverley or Matt?
So most people aren't going to have COVID pneumonia, and it's COVID pneumonia that brings the prothrombotic state. So yes, if they start getting really breathless and need hospital admission, I can assure you they will be anticoagulated in hospital. Post-discharge, the national guidance, which was published back in the middle of June, suggests to give thromboprophylaxis post-discharge. So we are using low molecular weight heparin and DOACs for 2 to 4 weeks because they are so prothrombotic. And the average COVID patient has nearly a month on intensive care. They've lost all their muscle bulk. They really aren't very mobile. They're very fragile, and they probably need extra thromboprophylaxis. We're just at the moment trying to get a trial going to look at extended, by which I mean post-discharge thromboprophylaxis in the COVID patients. But somebody who has it mildly doesn't need anything.
Yeah. But, I mean, I've certainly seen what I think is being COVID pneumonia in patients in the community who've survived. Do you think we should anticoagulate them better for me?
I think it's down to you. If they're not very mobile, I would think about it. I've actually seen a hospital consultant who clearly had COVID pneumonia at home and didn't go to hospital, very stoical, and I'm not going to hospital. And he's had a DVT afterwards. So yes, I agree there's an issue there. And giving standard thromboprophylaxis is very low risk. So something like Fragmin 5000 or Clexane 40, but they have to be able to self-administer, or then you're going to have to get district nurse in. And I don't know about your district nurses, but we're a little bit short. Can you access that in your practice?
Yes, we still can, and we've actually had our practice nurses standing in for district nurses and vice versa. So
Okay.
I think we've managed it. But we're a compact, 109,000 patient PCN stroke CCG. So what about DOACs? Would you consider using a DOAC in those patients?
Sorry,
I'll bring you in a minute.
So if you look at extended thromboprophylaxis globally, then in medical patients in the US, the DOACs are licensed. So rivaroxaban and betrixaban are licensed for extended thromboprophylaxis. Low molecular weight heparin isn't, because although they reduce VTE, there's a bleeding risk associated with them. So it's betrixaban, which of course we don't have in the UK, and rivaroxaban, low-dose rivaroxaban in the States. And most of us here feel you're so prothrombotic with COVID, you need to go home on something. And if you can't get hold of a district nurse and they can't self-administer, we would give a DOAC. And actually, this morning I've been having calls with the DOAC companies to try and get a trial going of extended thromboprophylaxis, of different lengths of thromboprophylaxis post discharge from hospital. The naughty NIHR CMO portal where you apply for research grants has turned down the very, very good trial that was put in because it wasn't funded. So we've got to find some funding, which is crazy, I think, in the time of a pandemic. We need an answer, but because it's not funded, we didn't get the go-ahead. Okay, don't start me on this.
No. Time for that. We'll discuss it another time.
Yes.
Matt, did you want to make a comment there?
I just wanted to comment that there is a group of patients who are going to need long-term anticoagulation, and they're going to be the people where the AF was revealed at the time of their pneumonia. We know that nasty chest infections can demonstrate AF, and that AF does not get better. It's there, even if it was paroxysmal. They need appropriate risk assessment using the CHADS-VAS score, whichever score you wish, and then anticoagulation in the long term. So don't forget that there is going to be disease that we always recognise, and there's nothing that gets better.
Yeah, absolutely.
There is only AF. And if the AF is identified, it should be risk assessed and anticoagulated, even if it's paroxysmal, anticoagulated appropriately.
And one group of patients that, there's a question here, but I've seen as well in my own practice, are these patients with a persistent cough, shortness of breath on exertion, often they've had a COVID test that's been positive, but they've not been in hospital. Obviously, we know the difficulties with the COVID negative tests as well. So is there a sort of post-infective inflammatory lung disease there? Someone has asked, is there a place for inhaled steroids? As long as we've excluded PE. And there's also a question that goes on about the likelihood of pulmonary fibrosis. And are we going to see rapidly progressive fibrosis in patients? Can I bring Katherine in there and maybe bring you back in, Beverley?
Yeah, so lots of things there. I mean, interestingly, I saw a post on the PCRS forum this evening about a respiratory nurse specialist who had seen 2 patients with no previous history of atopy who have had COVID and are now presenting with asthmatic symptoms and have actually responded to inhaled corticosteroids. I don't know whether that's the thing, and it may just be a coincidence, but I suppose we're learning all the time, aren't we? And I think the evidence that we've got from SARS and MERS is that you know, if you have you know, ARDS, then you are more at risk of developing you know, a pulmonary fibrotic picture. Probably more common in those patients who have had a severe COVID episode and have been on intensive care unit. Probably less likely for those patients who have milder disease and have been managed in the community, but it's absolutely something that we need to be looking out for. And I suppose it's something that we should be looking out for anyway, regardless of whether patients have had coronavirus or not, because it's amazing the number of you know, instances of pulmonary fibrosis that I've picked up that have been misdiagnosed as COPD or bronchiectasis just by sort of taking the time to think, well, actually, this patient is not responding to things. They've had this chronic cough, listening to the chest, good history, and having a really low threshold for referring them for further investigations, such as a CT or into secondary care.
Great, thank you. Yeah. Did you want to make any comment about the pulmonary fibrosis, Beverley, or?
Well, just to say, I mean, the major breakthrough in the last few weeks has been the use of dexamethasone in those in critical care, and it's reduced mortality by about a third. And what seems to be going on in those who are stuck on the ventilator for a very long time is this profound inflammatory state without any obvious evidence of active COVID. And it's like the COVID sparked it all off and it won't stop. Whether there's COVID glycoproteins around, whether it's sitting in a hidden way in the endothelium or something like that, we don't know. So it sounds fascinating to hear that some people have ongoing chronic cough, and it does sound like steroids might be useful, but we need some trials here, don't we?
I think we do. I mean, I've certainly got a lady who actually has Still's disease, which is adult Still's, and I have no doubt she probably had COVID back in December, given the symptoms she had. And since then has been breathless on exertion, had a persistent cough, eventually was referred to respiratory, who you know, did a telephone consultation, etc. And she's been fantastic since she went on inhaled steroids. Is it late onset asthma? Is it post-COVID asthma, as they've labelled her? I think we're learning all the time, aren't we? Now, we have reached 8:30. I think we've answered a lot of the questions. There are still some questions there. Matt's waving his hand. Do you want to say something, Matt?
Well, I just wanted to quickly comment on the 6-lead ECG in diagnostics.
Oh,
if you're looking at rhythm, 6-lead, 3-lead, fantastic. You're looking at rhythm. You don't know what's happening on the anterior wall of the heart. So it's a diagnostic ECG. I'm afraid it's not a diagnostic ECG. That needs to be 12 leads. You've got to have the precordial set. For rhythm monitoring, if you think somebody's in AF, it's so you don't have to necessarily have to strip the patient off. But as a diagnostic ECG, you cannot equate it to a diagnostic ECG for anything other than cardiac rhythm.
Yeah, I'd agree with that, absolutely. And one very quick question. Is stroke commonly associated with COVID-19? The answer is yes, isn't it? You know, and Beverley's nodding her head there. I've certainly had patients who've had COVID and had a stroke and come out on full anticoagulation. Any comment, Beverley?
So we know we have increased stroke rates with any acute infection, but I think it's much more severe with COVID. We haven't really got any numbers yet. And we've got this amazing prothrombotic state, and usually they've got pretty atherosclerotic arteries, so we should expect high rates of stroke.
Okay. Well, I think we've had a fantastic session tonight. I'd like to thank Beverley, Matt, Katherine. I'd really like to thank Jo Jerome, who has come up with the idea, pulled this together. She's Chief Executive of Thrombosis UK. I'm sure many of you on the call know. And I just think it's been a wonderful session. I've certainly learned a lot. So the webinar's been recorded. It'll take about 24 hours for it to be downloaded and uploaded, and it will be shared for free, open access as soon as it's ready. Joe's going to email all attendees with that, with a link to be able to view it again. And we will look, if you all agree, to let us put it on our PCCS website too. There have been a few requests for the slides, and I think what we'll need to do is ask all our speakers for their permission to put them up on the website. So I'd like to thank you all for a great evening. We've had, you know, at one point approaching 300 people actively participating. And I'm actually going to hand back to Joe, who initiated all this to close the session.
Thank you, Ahmet. I would just like to say thank you actually to all the speakers and yourself. This wouldn't be possible without your time and your passion and dedication to provide this, so thank you. Can I also just let everybody who's attended know that the CPD certificates will be emailed to you at the beginning of next week, and they will sort of come out into your inboxes. If you haven't received it by the end of next week, just contact me. But they take a couple of days for us to process, and then they are with you. But otherwise, thank you very much to all the speakers. Thank you to all the attendees for joining us tonight. Please visit Thrombosis UK website, where there are plenty of resources. We're always willing to share and discuss with you. And I look forward to future webinars in the future. Thank you very much.
I'm going to say a couple of quick other things. I do think two of the learning points here we must take away are that please don't forget VTE. You know, DVT and P are common. They're common in non-COVID patients too, so we should always be aware of that. And I think a really good point that Katherine came up with, which we forget a lot, don't we, is get back to basics, take a good history. Yes, examine patients if we can, but you know, a good history tells us so much. And just a little plug for the Primary Care Cardiovascular Society too. We're a charitable organisation. We have over 300 members now. And if anyone has an interest in CVD, free to join us, visit our website.